All right, so the indications for pressure control, you know, I can tell you my indication. I will never use this. This is the bellows. This is almost the first mode of ventilation with a little bit of modification, as we talked before, right? In fact, in some hospitals they call it CMV still. You know, it is the first mode of ventilation. Things advanced. I'm sorry. You know, like I'm sorry that you like the first mode of ventilation, but there's no different than having the medical student do like this with the ambu bag. That's exactly what you're doing. You know, so it's the simplest mode of ventilation. You're not using the vent to your advantage. I think we moved generations after this. You know, so I wouldn't use it at all. But when I go to a hospital that uses volume control, I have to respect them. You know, if I'm not the chief there, I can't change things, right? So I just go there and respect what people are doing. But in certain situations, I will stop my feet, and you should do the same, and say, I have to use pressure control. What are the 3 indications that you absolutely have to use pressure control? So we talked about one 2 minutes ago, 5 minutes ago. Remember the air hungry patient? When we reach to 100 liters per minute flow, if he's still air hungry, we give him pressure control, because pressure control doesn't care what you need out of the flow. It will reach from this pressure to this pressure instantly, and give you whatever flow it takes to achieve that. Right, so we'll give you unlimited flow. The patient rarely have air hunger in pressure control. So number 1, air hunger. Number 2, high peak airway pressure. Okay, I'll tell you when. Everybody knows that everybody knows, and I don't want to make fun of people, but everybody knows that in asthmatics, you put the patient on volume control, and the asthmatic patient will have a high peak airway pressure, and everybody will tell you, don't worry, the lungs are not seeing this high peak airway pressure. What injures the lung, this is dynamic compliance. What injures the lung is the static compliance, right? Which basically like this. So if your peak is 40, but your plateau is 25, the lung is seeing the 25. That's what can injure the lung. And that's well known in asthmatics, and it's true. I'm not debating that it's true or not, it is actually true. But so we'll allow patients who are asthmatics to have this high pressure just to overcome the narrowing, and after the narrowing it goes to alveoli, and the alveoli will only see 25. Okay? But until when? Until what pressure? Like what pressure you will give to, then you're gonna say, nah, now I'm scared now, I can't give anymore. Like 70? Like, are you gonna accept 60 pressure, 70, 80 of pressure? Of course we're not going to accept that. Of course. Huh? So everybody has his own number. So I have 45, I'm not going to do it. If it's 45, I'm putting him on pressure control. Why not? Put him on pressure in a mode that will limit the pressure, but in the same time will give me a good tidal volume because of the eye time. So that's another indication there. And then the third indication is hypoxia. Right? So, and that we'll spend about maybe 15 minutes talking about why hypoxia is better with pressure control than in volume control. All right, so let's talk about literature, because we love literature, right? Everything has to be according to the literature. By the way, just as a tangent, the APRV has been studied recently, about 1.5 years ago, against low tidal volume ventilation in a hospital in China, so quote unquote China. People here, that's one of the criticisms. This is China, doesn't apply here, really? And showed that it's actually much better in mortality, and much better in length of stay and length on the vent, like days on the vent. In fact, it was too good to be true, actually. Like, the days on the vent went from 3 days on the vent on APRV average. The volume control was 23. So I don't know. I mean, it could be a lie. Maybe somebody just like falsified everything. But that's what we have. Statistically significant, all of this. But when it came to mortality, the significance was 0.053. So people said we're still not going with the API. Okay, I can't get you a study, a smashing study. It just look at the physiology. The physiology makes sense, and everything else makes sense. But we'll talk about that. So anyway, so are there any studies for this? So basically, what is the most famous? Well, you know what? Let's not talk about it now. We'll talk about it the next time.